seizure, that doesn't make you an epileptic. Okay, if you have, you know, I was a resident in Cincinnati Children's in the 90s. Some of the kids would take too much alcohol, too much coke or something. They would be dropped off in the ER by their friends, and they have had a seizure. That doesn't mean that they're epileptic. We do a full evaluation, but that doesn't mean they're epileptic. Okay, does that make sense? Okay, so let's go to the other definition. So what is epilepsy? Okay, so we say epilepsy is a chronic brain disorder characterized by recurrent, unprovoked seizures. Okay, so what is, I think another lady asked me, what is epilepsy? Seems to be such a big name. And I try to reassure families that when we say epilepsy, it's 2 or more seizures. Okay, so when you have 2 or more seizures, you know, you're considered an epileptic. However, it doesn't mean that that's bad. But that just tells the physician that we may need to be more aggressive with regards to treatment. Now, if you have had 2, 3, or 4 febrile seizures, does that make you an epileptic? What do you guys think? No, because what is my definition here? You want to look at this recurrent, unprovoked seizures. Okay, meaning you're just sitting there minding your own business and suddenly you have a seizure. Okay, but if you have a fever, there's a cause for the seizure. That means for the definitions. And you know, whenever I give a lecture to families, to medical students, to residents, to physicians, you know, in a closed setting like this, I always say, if you have any questions, please, you may want to just raise your hand and stop me. So it's more of an interactive rather than just I'm speaking to you guys, okay? So feel free. Okay, epilepsy syndromes. We talked about that earlier. What are epilepsy syndromes? So there's like the International League Against Epilepsy has grouped certain seizure disorders. So we have what we call benign temporal epilepsies, juvenile myoclonic epilepsies. There's probably maybe 15 or 20 of these around. So why is that important? It's because the age of onset is different, the treatment may be different, the grouping are clusters, and then we even match the EEG depending on the epileptic syndrome. Okay? So for example, you have this, in your group we have wolf-hirschhorn. Now within wolf-hirschhorn, it sounds like there's different epileptic syndromes just by listening to you guys. So your physicians, your neurologists may treat you according to the epileptic syndrome. Epileptic syndromes may have different forms of treatment, so we tailor it against that. Okay? Okay. Epilepsy classification. I think Dr. Battaglia said by talking to you guys, you kind of recognize this. Let me just go over this, okay? So what's the epilepsy classification? It's very important because we treat it according to epilepsy syndrome. So I always say there's seizures that come from one side of the brain, and that's on the left side, okay? Partial. It's coming from one side of the brain. I always said God created it so that the left side of the brain controls the right side of the body. The right side of the brain controls the left side. So for example, in stroke, if you have a stroke on the left side, I'm going to get weaker on the right side. If I have a seizure here, then it may be after the seizure, I may be weak. So that's partial. The treatment to that is usually the carbamazepine. So I heard some people talk Tegretol, Trileptal now. So in some of, it doesn't necessarily mean that you're on Tegretol, that it's bad if you have wolf-hirschhorn syndrome, okay? That means if you're on Tegretol, Trileptal, your initial EEG may be compatible with the partial seizures. And on the right side is your generalized epilepsy. That means seizures that start on both sides of the brain. And those are the different ones, okay? Let me talk about, okay, so these are like probably what you guys see, myoclonic. What are myoclonic seizures? I think everybody knows what a myoclonic seizure is, right? Brief, sudden jerks of the body, okay? So I may have, not necessarily wolf-hirschhorn, some kids who are like, you know, like doing like the Wii or like on computers a lot. They may just have start kind of jerking real quickly and then suddenly have a grand mal seizure, okay? So those are myoclonic, brief, sudden contractions of the body. And you don't necessarily have to be out, okay? You can just have a brief and you may just like be awake and normal, okay? Atonics. Atonics, walking, and suddenly brief drop, okay, loss of muscle tone. And I call sometimes a lot of kids with atonic seizures, I say my badge of dishonor as a physician who treats epilepsy, because they may have big old goose eggs on their, just boom, you know, they may be standing waiting for their bus, and suddenly, boom, you know, their friends don't even have time to catch them, or their mothers while waiting in Walmart, suddenly, boom, okay, and then you have this big black eye. Sometimes I have a kid that had like a laceration of the chin, and the family goes, oh, he was just clumsy. As a physician, I'm like, oh, no, I mean, that just might not be clumsiness. I bet you maybe he had an atonic seizure, and I may need to reinvestigate, am I on the right drug, okay? Absences, I think everybody knows absences, just kind of, I call it when I'm talking to my husband, and then blah, 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 and you know, he's just kind of staring and not responding to me. But that's just like a Y chromosome thing, right, guys? And so I tell him maybe he's having an absence seizure, okay? So it's a brief off and on. So just, I tell families, it's just turning the lights off. Boom, 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 okay? Off, on, and the EEG is beautiful that way. Normal EEG suddenly have the brief burst, and then the brain triggers again, just like nothing happened, okay? Unlike partial seizures, which can mimic absence seizures, guys, okay? So you can have staring, but usually kids with partial seizures may suddenly just stare, and sometimes even chew, and then get sleepy afterwards. Okay, and how do we distinguish this? We distinguish it by EEG. Okay, so sometimes I think that's why you earlier heard video EEGs are very important. Okay, because we kind of go, okay, am I on the right medicine, or is it a partial absence? Because it may be very hard to tell. So even my medical students, I always tell them, when you're getting a history, ask them, what were you doing when it happened? How long did it happen? What happened after that? Okay, so I tell my medical students, just don't come up to me and tell me, Dr. Emily, the child had 3 seizures. I have to ask them, what was the child doing during the seizures? Okay? All right. So I think you guys know, this is what you describe as grand mal. Okay? I always say this is like, you know, like ER kind of seizures. You know, the TV ER, very, very dramatic. You can even tell it. You know, anybody knows if you're in Walmart, oh, that's a seizure. Okay? Sudden, kind of tonic. Tonic is the extension phase. Clonic is the jerking phase. Okay? And then you have the breathing issues. During the tonic, it's go, you know, and then you suddenly start twitching. So these are the kind of scary episodes when families say, I'm scared to have a seizure, because these are really scary to the families. Okay, and I think we talked about a little bit about simple. So simple comes from one side of the brain. Complex meaning you start altering your consciousness. So what's the difference between simple and complex is the alteration of consciousness. Okay, so simple, Mom, my seizures are coming, my right side's jerking, they're totally talking to you, they're normal. That's because it's just probably starting on just one side of the brain. That's when you hear that aura also. Okay, so some of your kids, as they get older, they may be able to tell you, Mom, it's coming, it's coming. Okay, or they may look funny. Some of them may say abdominal rising sensation. That's a temporal lobe seizure. Some of them may have funny taste in their mouth. So the more verbal the child, the easier it is for me to say, okay, so when I walk in and Lauren's family asks me, I sometimes ask Lauren, what do you feel when you're having seizures? Some of them, I can't tell. Some of them can really tell me in great detail what happened before, what happened after. Okay, so that's very helpful for the doctor. So that's sometimes we call it like a seizure calendar. Okay, so during this, if you ask a kid a week later, I don't remember. So you may want to ask the kid during the seizure. Okay, all right. So I'm going to use Lauren's history with the approval of Amanda here, because this is we call it HIPAA. You know, this privacy laws. So when Lauren first came to see us, she was 6 months old, and mom and dad said there's some repetitive twitching and staring episodes. So I think she had a routine EEG, and that was normal. So we brought her back in for, I think, a 24-hour EEG. Let me just show you what her EEG looked like. So very nice and sinusoidal. I call EEG like waves of the sea, okay? And it's the same, you know, with technology has advanced. MRIs are so different. You know, if you, like maybe Dr. Carey's time is just CT scans, now there's MRIs. EEG, it's just gone electronic. There's not much difference with what the EEG waves look like 20, 50 years ago. They're still the same. It's just that now we have video EEGs that are kind of computerized. Okay? But this is Lauren's. Very nice waves of the sea. Okay? A little bit on the slow side, but we didn't at that point see any spike and wave discharges. And so anyways, let's go on. Okay, at almost 2 years of age, they came back, and I think they already had the diagnosis because their geneticists did hybridization studies. When you hear microarray, which has been available probably in the last 3 or 4 years, and actually at Nationwide Children's, it's available in our lab. You don't have to send it out anymore in the past 2 years. So I think at that time they had to send out Lauren's labs. But at 2 years, almost 2 years of age, and I think I tried to look through Lauren's charts, and she has 2 chapters. So in the second chapter, that's I think 2 years of age, myoclonic jerks and grand mal seizures. Okay, and so let's go to the. There you go. So you remember the previous EEGs, guys? Waves of the sea. Remember that? And then here it's kind of called the angry EEG. High amplitude spike and wave. I don't have a pointer, but see that, guys? You see that? That's a spike. Okay, I call it like a fence. Hi, babe. Like a fence. It's if you put your finger on the spike, you might get hurt. Oops, you know. So this is very different now. Okay, then maybe one more time. And then this is another recording, and that was when she was about 2 to 2.5 years of age. Okay, so at that point we were like, oh wow. Okay, so we probably at that point we needed to start medicine. Okay, and I think, correct me if I'm wrong, we started Topimax first. At that point we started Topiramate or Topimax because it's a fairly, I think she was, when I asked Amanda last night, she was having a bajillion seizures. Okay, so she was having a ton of seizures. And Topimax is a fairly strong medicine. We like Topimax. The only thing with Topimax that I worry about, especially in your population, because there are a lot of kidney problems, also it has a lot of cognitive issues. Okay, so a lot of the physicians you probably would hear sometimes our name for that is Dopimax, because it kind of really slows down your thinking. Okay, and you have some word findings, and kids with developmental issues. The one thing that I ask parents when I'm treating children with developmental issues, the first thing I ask, how's school, how's development? Okay, okay. So this is, I think we were talking about, you all were asking about medicines. So on your left side is older meds, new meds. Okay, obviously for us now in 2008, we probably use the new meds more because the drug companies develop the new meds to obviate the side effects of the older medicines. Okay, so there's a lot of research for newer medicines because in the old days, we have on this side, this bottom two, and I think it sounds like in Italy they use this a lot more. Probably because this one has more of the liver dysfunction, liver failure. So anytime I mention liver failure, that really, the parents go, ooh, we don't want that. Okay, so but I always have to tell everybody the side effects. It's just like if you start in a Lipitor, right? You know, you have myopathy with it, you have to know all the side effects. So as a physician, as a mother, as a father, you want to have an informed decision. So we don't use these medicines all the time. I finished my training, I won't tell you, maybe over 15 years ago. And that's what all we had, okay? So either we kind of use this in combination with the other. So the nice thing about 2008 is look at all the newer medicines we can use now, okay? It doesn't mean the newer medicines have no side effects, but it's still lesser than the old medicines. Okay, so these are the new medicines, and I think I was talking to the physicians last night, asking because a lot of the newer medicines are approved more in Europe before America, because FDA has more strict standards, but they said they're becoming more strict in Europe. So a lot of the newer medicines are first tested in Europe, so they have more of a life there before it arrives here. So a lot of, like, for example, Keppra, it's a Belgian drug actually that was approved here recently. It's a lot of the medicines. So there's probably 2 more medicines or 3 more medicines coming up in the pipeline right now. There's maybe 1 medicine coming up this year that's a cousin to levetiracetam. So as physicians, why do we need newer medicines? You have a ton of them. That's because we have kids with intractable epilepsy. Okay, seizures that you're asking me, I think a fair amount, it's like a 50-50 thing it sounds like. Kids who still have seizures despite medicines, okay? All right.
Just a question on that.
Yes.
Is there the newer version of, or is there a phenobarb?
There's no newer version of phenobarb, no. That's a good question, but no. So a lot of the newer meds like phenobarb acts on what we call the GABA receptors. So a lot of the designer drugs since 2008, we found out that neurotransmitters are GABA, glutamate. So now the drug companies are now analyzing with regards to just mainly on the neurotransmitter. Okay, so they're designing the drugs for that particular effect. Okay.
I just have a question. That the first drug, I guess the other name was Neurontin.
No. Okay. Yes.
That's been around for a while, but
yes.
It seems like for neuropathy.
Well,
but is it something now that they've started using for seizures?
No, actually, yeah, good. So Neurontin was first, this designed specifically actually for epilepsy.
Oh,
so it was, yeah, so it's a GABAergic drug, they thought. And then, it's not really that GABAergic. But actually, it's making, the drug companies making millions of dollars on neuropathy rather than epilepsy. Because we think gabapentin is not a very good drug for epilepsy or intractable epilepsy. But it's still, it was first designed for epilepsy.
Oh,
yeah.
Yeah. I've seen it more for neuropathy.
Yes, there's more money to be made there because it's really a very benign, it's not very strong epilepsy medicine.